Good afternoon, and welcome to today's webinar, The After Effects of Breast Cancer Treatment. My name is Michelle Dixon, and I am the Program and Development Director for Massachusetts Breast Cancer Coalition, and I'd like to thank you all for joining us today. I am very pleased to welcome today's speaker, Dr. Jill Oxley. Dr. Oxley is breast surgeon with Cape Cod Hospital and the director of the hospital's breast program. She received her medical degree from Yale University School of Medicine, where she became interested in breast cancer diagnosis, surgery, and treatment. As part of the medical community, Dr. Oxley is a member of the American Society of Breast Surgeons, as well as a fellow of the American College of Surgeons. She has received numerous honors from Harvard-Radcliffe, where she pursued her undergraduate degree in biology. Dr. Oxley has been on the staff of Cape Cod Hospital for over 15 years, and she is moderator of the Cape Cod Hospital Breast Cancer Case Conference and the chair of the Cape Cod Hospital Breast Program Leadership Group. Over 3 years ago, she herself was diagnosed with breast cancer, providing her with an expanded perspective of the patient experience. And we at MBCC are honored to have her as a member of our board of directors. Dr. Oxley, welcome.
Thank you, Michelle, and thanks everyone for taking a little of your time to spend with us this afternoon. So I'm going to talk about the after effects of breast cancer treatments, which is a pretty big topic. So if we're going to talk about after effects, well, how many people are we really talking about? So for 2020, the American Cancer Society estimates over 276,000 cases of invasive breast cancer will be diagnosed, and over 48,000 new cases of non-invasive breast cancer. So that's 1 in 8 women, or relative risk of 12.8%. Of these, nearly 6,700 will be diagnosed in Massachusetts. As far as deaths go, the American Cancer Society also estimates over 42,000 deaths from breast cancer this year. That risk is much lower, only 3%, or 1 in 39 women will die from breast cancer. And again, 780 in Massachusetts. Mortality has, fortunately, been decreasing, though, since 1989. And so what that means is that our survival is improving. Survival is highly dependent on the stage of diagnosis and other variables such as the tumor subtype, but overall, about 91% of women diagnosed with breast cancer will still be alive at 5 years from diagnosis, 84% after 10 years, and 80% after 15 years. So right now, there's over 3.8 million women alive who are breast cancer survivors. Estimates vary, but it's reported that as high as 90% of these women, however, report physical problems after treatment. So breast cancer treatment can basically be divided into 3 categories. First, there's surgery, and that's surgery of the breast with or without surgery on the lymph nodes in the axilla or underarm. Second is radiation therapy. And then there's medical treatment, which can basically be broken down into chemotherapy and endocrine or hormonal therapy. The National Comprehensive Cancer Network defines a survivor as on this slide. An individual is considered a cancer survivor from the time of diagnosis, during and immediately after treatment, and through the balance of his or her life. Family members, friends, and caregivers are also affected by cancer. There are many parts to survivorship care. And again, part of these guidelines for survivorship are listed here. Survivorship should include prevention of new and recurrent cancers and other late effects, surveillance for cancer spread or recurrence, screening for subsequent primary cancers, assessment of late effects, psychosocial, physical, and immunologic, interventions for the consequences of cancer and treatment, coordination of care between primary care providers and specialists to ensure that all the survivors' health needs are met, and plans for ongoing survivorship care. This topic is so broad that survivorship itself is divided into 12 subcommittees of the NCCN. And you can see them here: cardiovascular disease, anxiety, depression, trauma, and distress, cognitive function, fatigue, lymphedema, hormone-related symptoms, pain, sexual function, sleep disorders, immunizations and infections, second cancers, and healthy lifestyles. But for this talk, I'm going to focus on these 4 parts: upper body effects, neurocognitive effects, cardiac effects, and secondary malignancies. Upper body effects of breast cancer treatment are due to surgery and/or external radiation therapy. And these can also be subdivided then into two main categories: lymphatic problems and then musculoskeletal and neuromuscular disorders. The primary lymphatic problem is lymphedema, with axillary web or cording as part of that. And then all of these pain issues that you see: post-mastectomy pain, rotator cuff syndrome, arthralgias, etc. Lymphedema is one of the most feared complications of breast cancer treatment. By definition, this is accumulation of fluid in the tissues due to injury or obstruction of lymphatic vessels and/or removal of lymph nodes. Fluid can accumulate in the hand, the arm, or the breast of the treated side. If untreated, this can lead to tissue damage and increased risk for infection. It can occur in up to 7% of patients who have a sentinel lymph node biopsy, which is just removal of a few lymph nodes from the underarm, but can be as high as 20 to 40%, especially when someone has had more lymph nodes removed in a full axillary node dissection, and if radiation therapy is administered as well. This lymphedema development can cause a vicious cycle of increased pressure on the lymph channels due to the fluid in the tissues, which worsens the valves within the transportation of the lymph through the channels. And so you get this vicious cycle of worsening lymphedema. The risk of lymphedema is lower with sentinel node versus axillary dissection, but there are some other predictors of risk of lymphedema development as well. So axillary node surgery increases the risk of lymphedema in both the arm and the breast. The number of nodes that are involved with cancer, in addition to just the number of nodes removed, can be associated with a higher risk of lymphedema, needing radiation, or postoperative issues such as hematoma, blood clots, seroma, fluid, or infection. Also, patients who are obese or have poor shoulder problems before surgery are at increased risk of developing lymphedema. Lymphedema is divided into 4 stages. The first of them, or stage 0, there is no visible swelling. However, the patient can report a feeling of heaviness in the arm, tightness, fatigue, discomfort, or decreased mobility. Stage 1 shows mild swelling, it's pitting edema that usually resolves with elevation. Can resolve completely spontaneously as well. Stage 2, the arm is visibly swollen, the edema is non-pitting, and that's when the tissue begins to fibrose or thicken, and at this stage the lymphedema is likely irreversible. Stage 3 then is irreversible skin changes, including fatty deposits in the tissues, increased pigmentation, and this can also be known as lymphostatic elephantiasis. The diagnosis and early intervention is most important in the treatment of lymphedema. The history and physical, however, is very subjective, but it can be important to rule out signs of recurrent cancer, which can also cause lymphedema, or a blood clot, the DVT in the upper arm, which can also cause swelling. There are other more objective ways to assess for lymphedema, arm measurements being one. This is fairly easy, however non-standardized. Water displacement measures have been considered the gold standard. This measures the volume of the limb, but the equipment is bulky and needs to be cleaned between patients. Bioimpedance spectroscopy is very accurate as well and much more portable, and it can detect very subtle changes in our measurements. However, this is not consistently reimbursed by insurers. Most of the treatment of lymphedema is to prevent progression to the untreatable levels of 2 and 3. We want to reduce the risk of infection and return the patient to normal function. So early intervention and education are key. There are risk-reducing strategies that have been around for years. However, there's little evidence to support them. We typically do recommend that the patient avoid having blood pressure measurements, blood draws, IVs, or injections on the affected side. Physical activity can play a big role in reduction of lymphedema, and there are occupational therapists and physical therapists specially trained in lymphedema management and treatment. The simplest of maneuvers can involve elevating the arm above the level of the heart, compression garments such as sleeves, gloves, or gauntlets, and even vests, and multi-layer short stretch compression bandaging. Lymphedema therapists are involved in this as well and can recommend these garments, these bandages, but they can also perform manual lymphatic drainage. Intermittent pneumatic compression pumps are an alternative to bandaging and the manual lymphatic drainage that can be done at the patient's home. Surgery is typically the cause of lymphedema, but can also be used to treat it with lymphovenous anastomosis, meaning attaching lymph channels to veins, or actually free lymph node transfer. But more recently, there are surgical techniques being developed to reduce or eliminate the chance of getting lymphedema in the first place. So axillary reverse mapping involves identifying the lymph nodes that are involved in the drainage of the arm at the time of the lymph node surgery for breast cancer to avoid removal of those nodes. LYMPHA, which stands for Lymphatic Microsurgical Preventive Healing Approach, or S-LYMPHA, which is the simplified version, is also a newer technique that's not widely practiced, but is becoming much more available, where when a patient is known to need a full axillary node dissection, these anastomoses connections can be performed to try to reduce the development of lymphedema. Axillary web syndrome is in part a lymphatic issue as well as a musculoskeletal issue. This is also known as cording. And what this is, as you can see in this diagram here, this is a pretty prominent one, but it's the appearance of these cords under the skin. They feel like al dente spaghetti, and they can run from the underarm, the axilla, all the way down the upper inner arm to the elbow, or potentially down to the wrist. They can also run down the side of the chest. This is thought to be caused by disruption of veins or lymphatics. It can occur within 1 or as long as 8 weeks after axillary node surgery or sentinel lymph node biopsy. The incidence is very variable, reported as low as 5.2%, as high as 72%. It can present with both pain and decreased range of motion. Unfortunately, this is not a long-term problem. This is benign. This has nothing to do with cancer, and it usually resolves by itself, but it can also be treated during lymphedema management therapy. The other main category of upper body effects have to do with musculoskeletal and neuromuscular disorders. So this table here lists many, many problems that can occur from breast cancer treatment. The first one I'll speak about is post-mastectomy pain syndrome. This is a chronic pain. It's a neuropathic pain or nerve type pain that it can occur in the chest, the underarm, and or the upper arm. It's called post-mastectomy pain syndrome, but any breast surgery procedure can cause this problem. Most commonly, it occurs after axillary dissection and or breast reconstructive surgery. The incidence, again, is variable, as low as 25%, but as high as 70%. It can occur right away, or it can not appear until months after surgery. The incidence may be increased in tumors that are in the upper outer quadrant of the breast, meaning closer to the underarm. It is fortunately less common with the sentinel lymph node biopsy versus the axillary node dissection. If a patient has to have the node radiation but doesn't have the dissection, then it's also less common, and older women are less likely to have this pain syndrome. Treatment is multifactorial. Physical therapy, including skin desensitization and myofascial release techniques, pain medications, both non-steroidal and potentially opioid, but hopefully not. And then intercostal nerve blocks are occasionally used. And then TENS units, which are transcutaneous electrical nerve stimulators. Rotator cuff syndrome or disease is a major cause of shoulder pain. And this, unfortunately, is common in patients with or without breast cancer treatment, but breast cancer treatment can certainly exacerbate this. After surgery, the patients adopt a protective type of posturing, worried that any uncertain movements may cause worsening pain. Radiation can cause misalignment as well, and so the combination of radiation and this protective posturing can lead to what's usually known as frozen shoulder or adhesive capsulitis, where they really can't move the arm at all. And this again can lead to another vicious cycle of complications, where the fear of pain causes decreased range of motion, which then further exacerbates the pain syndrome. This can be addressed early on with physical therapy and hospital-based exercise classes. Again, this can be addressed with lymphedema management, and then usually non-opioid pain medications are most helpful, and potentially steroid injections into the rotator cuff. Arthralgias, or joint pains, are another problem that are very common in patients whether or not they've had breast cancer surgery, but they can be worsened by various treatments. So chemotherapy can worsen arthralgias, aromatase inhibitor therapy, which is part of the endocrine or hormonal therapy, and it's actually quite common with aromatase inhibitor use. Up to 50% of women on these drugs will complain of pain. The most common locations for these pains are in the wrist or hand, knees, backs, ankle or foot, or the hip region. This can be treated with education about the side effect of anti-inflammatory drugs, opioids, again, usually not, and antidepressants such as duloxetine or Cymbalta. Aerobic exercise may help worsen the arthralgias as well. And then for arthralgias that are due to aromatase inhibitor therapy, one can be switched to another one. They have 3 to choose from, and then tamoxifen as the 4th choice, potentially for endocrine therapy. Cervical radiculopathy is our next pain syndrome. This is commonly referred to as a pinched nerve. Cervical radiculopathy can cause pain in the neck, pain in the arm, and arm weakness. It is not caused by breast cancer treatment, but it can worsen other disorders caused by breast cancer treatment. Brachial plexopathy is the last pain issue that I'm going to talk about. The brachial plexus is a group of spinal nerves that provide sensation and motor innervation to the arm. It supplies all of the arm muscles except the trapezius and the levator scapulae. Disease or damage to the brachial plexus can cause numbness, tingling, pain, and weakness in the arm, hand, or even the shoulder. It can be caused by a tumor or nodal radiation therapy. And since we're talking about mostly survivorship issues, I won't really spend any time on tumors, but the radiation effects. So radiation-induced brachial plexopathy can be divided into 3 clinical syndromes, all of which fortunately are fairly uncommon. The mechanism is thought to be damage to the blood supply to the nerves and or fibrosis of the tissues around the nerves. The first one is reversible or transient. This occurs immediately following radiation to the chest wall and lymph node region. Again, fairly uncommon, but potentially as high as 20%. It's characterized by both paresthesias, that's numbness and tingling, or weakness. The second clinical type of radiation brachial plexopathy is ischemic. This is thought to be due to venous occlusion, so problems with the veins, or arteritis, inflammation of the arteries. Fortunately, this is very uncommon with modern surgical and radiation techniques. The third category is radiation fibrosis. This is progressive and ultimately irreversible, and at its worst extent is known as flail arm. Again, the incidence is variable, can be as low as 0.6% up to 14%. It can occur months to years after radiation therapy. It most commonly presents with weakness, paresthesias, pain, can also cause lymphedema. There will be radiation skin changes visible. And then another rare complication of this is osteoradionecrosis, either of the ribs or the humeral head. Unfortunately, there's no proven methods for prevention. So when we're talking about treatment, the first issue is to rule out metastatic disease. Once that has been accomplished, then the focus is on pain management. So steroids can be effective, opioids, antidepressants like duloxetine or Cymbalta, and then gabapentin, otherwise known as Neurontin. Pain management can be supplemented with psychological, physiatric, or non-invasive neurostimulatory techniques. There's also potential role for more holistic approaches such as acupuncture and massage therapy. And then there is some data regarding anesthesia and neurosurgery interventions. So the nerves can be destroyed using chemical, surgical, or radiofrequency ablation. And there's actually reports of amputation. What may not be surprising is that this doesn't actually help the pain. However, amputation can improve the heaviness that's associated with a very numb, edematous arm. So I've never seen it, and I hope I never will. So moving from pain to neurocognitive effects. Cognitive complaints are very common during breast cancer treatment. It can be hard to distinguish this from a direct effect of treatment or part of the normal age-related process. There's lots of things going on during treatment: anxiety around the diagnosis, depression around the diagnosis, medications, and then fatigue. Persistent cognitive dysfunction, though, occurs in between 15 and 61% of patients. And when this is long-term, it's been referred to as chemo brain. But it's also been seen in patients who have not had chemotherapy. And a lot of the research is trying to figure out if this is due to other changes, such as post-surgical changes, the psychological effects of the breast cancer diagnosis, or something else. And so as illustrated in this table, this diagram, cognitive function is due to many effects with interacts with each other, along with direct impacts on cerebral functioning. We've got the treatment itself, host factors, psychological effects, immune effects, and then hormones. One of the potential factors that may influence the risk of cognitive dysfunction are these psychosocial factors. So the diagnosis of breast cancer as well as the treatment can both increase distress. And distress and depression are associated with deterioration in cognitive performance. When this deterioration and depression are severe, this is known as pseudodementia. Anxiety is also associated with worsening cognitive dysfunction. There may be some genetic predisposition to cognitive dysfunction from treatment. Studies of breast cancer survivors are also looking for common factors that increase risk of dementia in older adults. So one of these research areas is on the apolipoprotein or APOE4 allele. So allele is a form of a gene. There are also things known as SNPs, single nucleotide polymorphisms, involved in the catechol-O-methyltransferase gene that's involved in dopamine metabolism. There's also research in genes that are involved in inflammation, so tumor necrosis factor alpha, interleukin-1 beta, interleukin-6. These are all involved in inflammation, and uncontrolled inflammation can affect cognition as well. So these cytokines, or kind of cell signaling substances, are involved with both cancer symptoms and age-related cognitive decline. And studies have shown increased tumor necrosis factor alpha and IL-6, along with decreased hippocampal volume, hippocampus is part of the brain, have been associated with poorer memory and more cognitive complaints after treatment. Hormonal effects can play a role as well. And the hormonal effects of cancer treatment can be caused directly by hormonal or endocrine therapy or by the endocrine effects of chemotherapy. And it's been shown that women with chemotherapy-induced amenorrhea are more likely to have declines in cognitive function. So the endogenous estrogen, meaning the body's own estrogen, not estrogen replacement, has been shown to be important in cognitive function, especially verbal memory. The hippocampus, which is a part of the brain involved for memory and learning, has estrogen receptors, similar to what's being targeted with some sorts of endocrine or hormonal therapy. Estrogen has been shown to be neuroprotective. This mechanism may be by relieving oxidative stress by scavenging oxygen-free radicals. Estrogen has also been shown to have effects on telomeres. Telomeres are DNA protein caps on chromosomes which stabilize them. They do ordinarily shorten with age, and they have been shown to be longer in women with a longer reproductive life. The body's own estrogen is neuroprotective around the time of menopause, but has been shown to be neutral or detrimental later on. How do we know that there are these neurocognitive effects? Well, neuroimaging studies have been done to assess for this. MRI and functional MRI studies have shown changes in blood flow in both the hippocampus and the frontal lobes, even as long as 5 to 10 years after chemotherapy. These studies have shown decreased gray matter density and increased white matter density, and that's a similar profile that's what's seen in patients with Alzheimer's dementia. Since it's so difficult to really define these causes, it's hard to identify the at-risk groups, and so it's difficult to prevent these neurocognitive effects. Since there is such a substantial survival benefit to these therapies, it's not reasonable to withhold therapy to prevent cognitive decline. So the focus has been on management of symptoms with cognitive and behavioral therapy. And then there's a questionable role for medications, but that really hasn't been well defined yet. So the next topic I wanted to talk about was the cardiac effects. Now, cancer survivors as a whole are at increased risk of cardiovascular disease. Cardiac effects, also known as cardiotoxicity, can take years or even decades to manifest itself. And most survivors are at greatest risk 5 or more years after they've completed their treatment. So these cardiac effects can be cardiomyopathy or congestive heart failure, hypertension or high blood pressure, hyperlipidemia, arrhythmias, myocardial infarctions or heart attack, and cardiovascular accidents or stroke. Risk factors can be underlying high blood pressure, hyperlipidemia or dyslipidemia, diabetes, family history, age greater than 65, having received high-dose chemotherapy, having a low normal left ventricular ejection fraction, which is found on echocardiogram, atrial fibrillation, underlying coronary artery disease, structural heart disease like valve problems, smoking, and obesity. One of the specific parts of treatment that can have high cardiac toxicity are the anthracycline chemotherapy. Anthracyclines may cause this by oxygen-free radical production. Anthracyclines also intercalate or insert themselves into DNA, and this leads to problems with intracellular signaling and programmed cell death. By interfering with the DNA mechanisms, there can be lower numbers of cardiac cells available to help repair the damaged heart cells. One of the main risk factors for anthracycline-related cardiotoxicity is the dose. And with escalating doses from 400 milligrams to 550 to 700 milligrams per meter squared, the risk of cardiac toxicity went from 5% to 26% up to 48% in one study. Age is also a risk factor for cardiotoxicity from anthracyclines, pre-existing cardiovascular risk factors, prior radiation, and then other drugs. And as with the potential risks for neurotoxicity, there may be genetic variants that increase the risk of cardiac toxicity as well, such as these single nucleotide polymorphisms in the carbonyl reductase genes. And these are genes involved in drug metabolism. The time course of these effects can be acute. Fortunately, this is relatively uncommon. When it does manifest acutely, it's most likely going to cause cardiac arrhythmias, potentially heart block, or inflammatory disorders such as pericarditis or myocarditis, also left ventricular dysfunction. Fortunately, when it is acute, it is generally reversible. It's unclear if having acute effects increases the risk of future chronic cardiac toxicity or not. The chronic cardiotoxicity is most predominantly heart failure symptoms and a non-ischemic, meaning not related to problems with blood flow or coronary artery disease, dilated cardiomyopathy. This can occur within 1 year of completing treatment, up to 10 years later. The second drug that has been associated with cardiac toxicity is Traztuzumab, or Herceptin. Approximately 15% of invasive breast cancers have overexpression or amplification of the HER2 gene, which is the human epidermal growth factor receptor 2 gene, and specifically the new oncogene. Traztuzumab, or Herceptin, targets these HER2 positive tumors with a dramatic improvement in survival. However, it is associated with cardiac toxicity, especially when combined with anthracycline chemotherapy. This table contrasts the effects of doxorubicin, or one of the anthracyclines, versus Traztuzumab. And as we said earlier, the anthracycline chemotherapies are dose-dependent, can be acute or chronic, can cause CHF, arrhythmias, heart block, etc. Traztuzumab, on the other hand, is not dose-dependent. Fortunately, it's reversible more than irreversible, but again, it's an increased risk when given with the anthracycline chemotherapy drugs. The mechanism of Herceptin, is thought to impair the HER2 signaling in the heart. HER2 genes in the heart are involved in cardiac development during embryogenesis, and then during adulthood, the HER2 gene is involved with the growth, survival, and inhibition of the cardiac muscle cells, inhibition of the programmed cell death of the cardiac muscle cells. This risk is predominantly congestive heart failure, usually reversible, and again, not dose-related. So again, the improvements in survival with the addition of Traztuzumab or targeted HER2 therapy drastically outweigh the rates of cardiac events. So the focus is on monitoring toxicity. Early detection and early initiation of heart failure therapy and lifestyle modifications can decrease the risk of long-term problems. Echocardiography or other LVEF measurements such as MUGA scans are frequently used during treatment, and the prescribing information for Herceptin includes an echo prior to treatment, every 3 months during treatment, and then every 6 months after the conclusion of treatment for 2 more years. Now, unfortunately, it's not just chemotherapy that can cause cardiac effects. Endocrine therapy can cause cardiac effects too. And when we're talking about endocrine therapy, there's tamoxifen, which is what's called a SERM, a selective estrogen receptor modulator, and then aromatase inhibitors. Aromatase inhibitors are used preferentially in postmenopausal women whereas premenopausal women can only receive tamoxifen. Treatment with aromatase inhibitors, however, is associated with improved disease-free survival. However, there is no improvement on overall survival versus tamoxifen, and this may be related to cardiotoxicity. In the ATAC trial, which stands for anastrozole, which is one of the aromatase inhibitors, tamoxifen alone or in combination, women with pre-existing heart disease had cardiovascular events in 17% on aromatase inhibitor versus only 10% on tamoxifen. A more recent meta-analysis of 7 trials showed that aromatase inhibitor therapy was associated with a 26% increase of cardiovascular disease. Tamoxifen, on the other hand, has increased risk of thromboembolic and ischemic cerebrovascular events like stroke, however. So tamoxifen has fewer deaths from heart disease, but increased risk of stroke. The mechanism of these differences is not entirely clear. Tamoxifen decreases total cholesterol and LDL, or low-density lipoproteins, those are the good cholesterols, without effect on HDL. It may increase triglycerides. Aromatase inhibitors do not affect LDL. These changes in lipid profiles, however, have not shown to have a proven effect on cardiac outcomes. And so it's unclear if the difference between the two has to do with detrimental effects of aromatase inhibitors, protective effects of tamoxifen, or both. Now, radiation can have cardiac effects as well. Now, a lot of these were older studies and included many post-mastectomy radiation patients as opposed to post-lumpectomy radiation patients. But there was an increase of cardiovascular disease and cardiac-related deaths in women who had had radiation therapy. There does appear to have been an increased risk of coronary artery disease and/or non-fatal heart attacks with left-sided radiotherapy versus right-sided or no radiotherapy, however. This has improved, though, with newer radiation techniques. Risk is still increased with a combination of both chemotherapy and radiation. Risk is dependent on both the dose of radiation and the presence of underlying cardiac risk factors, as we mentioned before. Unfortunately, there's again a long interval between treatment and appearance of disease. This can be greater than even 10 to 15 years. So that's why it becomes important to avoid cardiac exposure to radiation in younger patients, especially. If you can minimize or eliminate radiation, or you can minimize or eliminate radiation-associated heart disease by keeping the heart out of the radiation fields. Small heart blocks can be used for upper outer quadrant tumors, so tumors closer to the underarm region. These blocks do shield a small amount of the breast tissue far medially and far laterally, so in the middle toward the sternum and then out toward the side. But fortunately, this has not been shown to increase in breast recurrent cancers. The radiation can be administered prone or with the woman lying face down, and that will move the breast off of the chest. There are also what's used more commonly called breath hold techniques. And so that's illustrated on this diagram here. With the deep inspiration, the heart moves inferiorly, so down toward the abdomen, and medially toward the midline. And so here you can see the heart is right in the middle, and these radiation lines are touching it. But with the deep breath hold, now it's further down and further away from the breast that's being radiated. The final topic I wanted to talk about is secondary cancers. This can be broken down into 3 main sections: radiation-associated, chemotherapy, especially anthracycline-induced, and endocrine therapy-induced. While we're still talking about all the bad things radiation can do, radiation-associated malignancies can occur by damage to the DNA. This again can have a long latency period. The effects can occur within 5 or as high as 20 years out from radiation therapy. Older studies showed a 5% risk of contralateral breast cancer and a 6% risk of other solid organ tumors such as the lung and esophagus related to breast radiotherapy. Newer studies, however, show that while 9 to 10% of breast cancer survivors will develop a second cancer, only 0.5% of these, 0.5%, are attributable to radiotherapy. There may be an increased risk of contralateral breast cancer in women who receive radiation under the age of 40 who live for more than 10 years. Also, smokers have an increased risk for lung cancer after breast cancer, and there may be a risk with BRCA1 and 2 and ATM carriers. These gene mutations, well, these genes are known to mediate the cellular response to radiation, and so mutations in these genes may involve factors which make a patient more susceptible to both developing breast cancer in the first place, but also subsequently developing a radiogenic cancer. Radiation sarcomas are probably the most feared radiation-associated secondary cancer, but fortunately they're rare. They occur approximately 10 years after treatment, as early as 2, but they've been seen as late as 50 years after treatment. And they may have a worse prognosis than de novo sarcomas. Lymphangiosarcoma is a very rare subtype of this. It involves the treated skin, and unfortunately it is frequently fatal. It's also one that occurs earlier, can be seen within 5 years of treatment. Anthracycline-induced cancer is most commonly acute myelogenous leukemia. So when this is therapy-related, it's known as TAML. And this accounts for between 10 and 20% of all AML cases documented. Alkylating agents such as cyclophosphamide can cause AML approximately 5 years after treatment. Topoisomerase II inhibitors such as doxorubicin about 2 years after treatment. And again, the long-term survival for this type of AML may be worse than de novo AML. Myelodysplastic syndrome is probably underreported in the literature. The risk at 10 years after chemotherapy is only approximately 1.8% versus 1.2% in women who have not received chemotherapy. So again, fairly low, but possibly underreported. And as we've seen before, for a patient who has both radiation and chemotherapy, they are going to be at higher risk of developing these leukemias than someone who has either one or the other. So endocrine therapy-induced malignancies, well, tamoxifen has been shown to have an increased risk of endometrial cancer, primarily in women over 50. And for this reason, along with many others, but for this reason primarily, postmenopausal women who still have their uterus are most likely to be treated with aromatase inhibitor therapy rather than tamoxifen. Unfortunately, the risk of endometrial cancer does continue at least 5 years after therapy stops. And the relative risk is about 2.2, meaning someone is 2.2 times as likely to develop endometrial cancer than an average woman with the population-based rates seen in surveillance, epidemiology, and end results data. The risk of endometrial cancer is increased with a longer duration of therapy, also obesity, and a prior history of hormone replacement therapy. Fortunately, however, most of these cancers are diagnosed at stage 1, and mortality is very low, only 0.2% in women who've had 5 years of tamoxifen. And tamoxifen does not increase the risk of other cancers. While it has been shown to cause liver cancer in rats, in humans it can cause abnormalities in liver function tests, fatty liver, and rarely cirrhosis, but it does not increase the risk of liver cancer in humans. Aromatase inhibitors, fortunately, don't increase the risk of other cancers. They have a lower risk of endometrial cancer than tamoxifen, and both tamoxifen and aromatase inhibitors lower the risk of contralateral breast cancer. So monitoring for endometrial cancer is basically a routine annual GYN exam unless there's vaginal spotting or bleeding. There's been no benefit shown from routine transvaginal ultrasound or routine endometrial biopsies. So I've said a lot of bad news over the last 45 minutes, but what does this really mean? Well, improvements in breast cancer screening and treatments have improved overall survival. Again, deaths from breast cancer have been decreasing since 1989. Unfortunately, many survivors will experience late and/or long-term effects of breast cancer and its treatment. So survivorship guidelines exist to help the cancer team and the primary care providers maintain and enhance wellness. Surveillance guidelines exist. This is taken from the NCCN guidelines. A breast cancer survivor is recommended to have a history and physical 1 to 4 times per year for 5 years. Periodic genetic screening for any changes in family history, referral to genetic counseling as appropriate. Post-surgical management, including education, monitoring, and referral for lymphedema management. Follow-up imaging, mammography every 12 months. There are no routine imaging studies to look for metastatic disease without symptoms, just as there's no indication for routine lab studies. For women on endocrine therapy, they're to be assessed periodically to encourage adherence to therapy. As we said a minute ago, an annual GYN exam for women on tamoxifen if their uterus is present without any studies or biopsies. Monitoring of bone health for women on aromatase inhibitor therapy or for women with ovarian failure from chemotherapy. Lifestyle management, studies have shown that regular exercise, maintaining a healthy diet, limiting alcohol intake, and maintaining a healthy body weight, BMI between 20 and 25, have all been associated with improvements in breast cancer outcomes. And then communication, coordination of care between the primary care provider and specialists, including a personalized survivorship treatment plan, including personalized treatment summary of possible long-term toxicity, and clear follow-up recommendations. And patients should be encouraged to have these follow-up visits, encourage screening, and medication adherence. Thank you for your attention.
Thank you, Dr. Oxley. We have a couple of questions that have come in, so in our last few minutes, I'd like to share a few with you.
Sure.
The first question is if you could speak to the role, if any, that there is research on, in terms of the role that toxic exposure from the environment plays in any of these after effects.
That's a difficult question. And with so many of these effects, especially the neuro effects, the cognitive dysfunction, there's so many factors at work that it's hard to know what's environmental, what's genetic versus what is actually caused by the treatment itself.
Okay, understood. And can you talk to us about if the follow-up post-surgery has changed in any way in light of the COVID-19 situation?
Yes, a lot of that's going to depend by institution, and there are guidelines that have been published by pretty much all of the major regulatory boards. So the American College of Radiology, the American Society of Breast Surgeons, the NCCN, NAPBC, all sorts of people have been issuing guidelines during these last few months, but anyone with symptoms is going to be treated the same during COVID-19 as if we weren't in the middle of the pandemic. A lot of providers are able to do video or virtual office visits to triage something, but in terms of routine follow-up screening, someone who is due for their annual mammogram a year or two after breast cancer treatment, unfortunately, that's going to be on hold right now. at most centers, but certainly anyone with symptoms can get in either virtually or in person and be addressed.
Okay, thank you. I'm going to take a moment just to see if we have any more questions. Well, I want to say on behalf of Cheryl Osimo, MBCC's Executive Director, and our Board of Directors, I want to thank you, Dr. Oxley, for taking the time to share with us this very informative discussion. And I want to thank all of our many listeners for taking time out of their day to join us. For those who are interested, the recording of this webinar will be made available later this afternoon on our website, and you can find that at mbcc.org. Dr. Oxley, thank you again, and to everyone, I wish you all a very good afternoon.
Thank you for the invitation.